Good morning. My name is Merati, and it's my privilege to report to you here from the United States. I'm here in Seattle, Washington, in the far upper northwestern part of the United States. It's my privilege to be invited by this distinguished group and my colleague, Dr. Nirakar, to be part of this experience. I thank you. I want to tell you a little bit about my hometown of Seattle, where I work. I'm currently a faculty member of the University of Washington. Here's our emblem. Seattle is known for a few things. Bill Gates there, and Jeff Bezos, Boeing, Starbucks, and of course, Kurt Cobain. I hope you have a chance to visit. These are my friends, Mount Rainier, and the old Space Needle. So things that are iconic of our city, but it's a place for the outdoors. I hope you have a chance to visit someday. This is my family and I on the coast out by the ocean, Pacific Ocean, exploring the tide pools recently. So we've been very lucky. I know lots of people are suffering, and particularly because of the COVID pandemic. So I'm aware of these things, and I will, when we talk about this, we'll be talking about the professional elements of COVID and its impact on our lives now and into the future. But I realize it's different for everybody, and I appreciate that. I have no financial relevant disclosures to make. I have nothing, no connections. I was involved as the immediate past president of our American Academy of Otolaryngology Head and Neck Surgery. I was involved in some of the final editing and approval of the Academy guidance that came out in spring. I know many excellent papers came out, some not so great here and there. I was involved in some of those too. But this particular document, the American Academy guidance, is one of the documents that I've seen from around the world that I think really captures the essence of where we are with COVID and otolaryngology broadly. Please note that it's called guidance, not guidelines. This is not a formal document. This has to do with what we believe to be the collective opinion and wisdom based on the facts that we have at hand about how do we function as otolaryngologists during the pandemic. Who do we see? How do we see them? What do we wear? What do we worry about? What expectations do we have of our patients and of ourselves? I think this is going to be a recurring theme throughout this recording, will be understanding and giving guidance, giving guidelines, giving support when there's so much variability all over the world in terms of the capacity. So I appreciate that. It was my great privilege to be the orator at the UPSI APSI conference about 4 or 5 years ago. I still have my medal right here. Thank you, Dr. Nirakar. It means a lot to me. And the incredible chance I had to listen and learn and share with my colleagues from all over, not just, of course, India, but Africa and the Middle East and all the other attendees there. So thank you to my colleague for including me on this too. COVID and laryngology, as I noted before, there's massive variation in the disease burden locally, every city, every town, every country, different peaks, different waves. We recognize this, we're living with this. I'm sensitive to this, as part of my academy job, I participate in some of the world region roundtables, and, it's one thing for a highly resourced country to come on and tell everyone, how they're doing things, which is great. I mean, it's commendable. But I recognize that not everyone has the resources. And even when you have resources, things aren't always done consistently. There's variance in the local disease burden. There's variance in the availability of personal protective equipment, PPE. And mostly we're talking about the masks in particular for clinical work, and whether or not we're talking about the hoods and the PAPR, as we call them. I'm sorry, I don't know of a different name. The contained filtered air respirator. Those are the PPE we're talking about beyond simple surgical masks and gloves and eye protection. Also, there's massive variability in testing. Now, testing is interesting because it's not just about the public health aspect of it. Testing within our management of day-to-day flow in seeing and caring for the patients in our community, testing also has to do with the risk to us as caretakers. If patients are sick, shouldn't be getting elective surgery. The testing is often done in asymptomatic patients in many circumstances to avoid the asymptomatic patient spreading the disease to us in the operating room or in the clinic. Is that the best use of testing? Well, in some situations it is. In some situations it may not be. And I think that is really an ongoing refinement that we're making in the care of our patients and our communities. Interestingly, just as one example, my institution, the University of Washington, has been among many leaders from all over the world about identifying health trends and where we're going nationally, domestically in the United States and beyond in terms of the disease burden. And interestingly, early on, when we hadn't really stockpiled or collected appropriate amounts of PPE, we were using testing, which we had in relative abundance, to help plan the use of our personal protective equipment. Some places had PPE but didn't have testing, and they went that direction. So it just is not going to be one size fits all. That's true for the early phases, for sure. It was true. It appears to be true for this phase, where we're still in the pre-vaccine time of this recording in summer of 2020. I don't know what it's going to be like in the long run. We're going to talk about that a little bit. What is it we do today in clinic? How do we care for these patients? I think that's important. Which patients should we see when resources are scarce? And then I think these two really big questions are, just boil it all away. Ultimately, laryngology, what you and I do for a living, is going to be about talking to patients and carefully, safely examining their larynx and their pharynx. Mostly, while it certainly can be done transorally or with mirrors and whatnot, I think still most of these are done with transnasal flexible endoscopy. And this is our workhorse. This is our examination. This is how we take care of our patients. This is how we take care of our own businesses and our practices. So is it safe? How do we do it? What do we wear? How do we manage the room? All of this matters. And the room, depending on resources, is an important consideration. We have to have, whether you're in a public hospital or private clinic, we have to safely engage our patients through the process. As a clinic medical director at the university clinic, we had to measure out the room. I'm sure you did this, each of you in some way. How do we get the flow? Well, it turns out if we have a patient who has a non-aerosol generating procedure, AGP, we seem to manage the room all right. Come, we clean, we wipe down, and we go. Even the management of the room has changed. Early on in the pandemic, when we were hearing about the fact that the virus could live on surfaces, I was scared. I mean, I managed my life differently, my home life, my car, my shoes. A lot of us did this. And while those things exist, we can measure virus on surfaces. It doesn't appear that that's a prominent or a dominant route for transmission. Does it mean we should be casual or careless in clinic? Of course not. We're still managing the clinic in terms of the surfaces by just thorough cleaning, but we are not necessarily giving time for the room to sit, depending on what happens in the room. And this is controversial. And routine visits versus visits with intervention. And I want to spend a few minutes on this. So first of all, going through this slide, which patients should we see when resources are scarce? Well, the triage is, this is in the heart and the mind of every otolaryngologist. Can't breathe, coughing up blood, worry about a tumor. These are the patients we see today, in acute infection, as well. When we were at the most stringent part of our clinical lockdown, we weren't seeing the vocalist. We weren't seeing the patients with globus who had already been seen. They didn't have a tumor, this sort of thing. And I don't think that's that hard. I think in my experience with the academy, when we were going through the guidance, it wasn't just about the doctors had a pretty good idea of who they should and shouldn't see. It was so that we could provide, in our case, a national society a set of framework so that those individual practitioners, could have the support and guidance from the academy to talk to their local officials. Hey, I need to see these patients. Look, this is what my academy says, for example. It's not perfect, but that's where a lot of it was. I don't think people were struggling with the decision of whom to see when patients couldn't breathe or coughing up blood and that sort of thing. I could be wrong on that, but I think that that part wasn't that hard, but it was important to get it written down. We didn't see a lot of patients beyond those categories, for example, in Seattle in late March and early April, but late April and early May, as the numbers trended well for our region, we started seeing patients, and we're now fully active clinically, but with all the precautions. The most important question, in my opinion, for laryngology is routine diagnostic flexible laryngoscopy, with or without stroboscopy, is that an aerosol generating procedure? Now, you've each seen a battery of papers, maybe even in this conference, about how if I perform this, there's a splatter of something over there 10 feet away. We hear these stories of super spreader events in choir practice, people talking and singing. These are alarming. I don't want to die of this. I don't want to give it to my friends and family. We're afraid, but what do we know? Do we know that those events can happen? Yes. Do we know that our asymptomatic patients passing simple screening, fever symptom, do we know that they're very likely to spread the disease to us when we're wearing personal protective equipment? It looks like we're okay. It looks like we're not seeing these events when precautions are taken. Specifically for diagnostic laryngoscopy, our academy guidance was pretty, I thought it nailed it pretty well. There are documents out there saying that flexible laryngoscopy is not an AGP. Well, I don't know about you, but I certainly have been AGP'd on during a flexible laryngoscopy. There are documents say it is, and I don't know that that's necessarily right always. We could prepare with that level of caution, but I think for me, and this is what we do at my institution, we treat it as a potential AGP. We treat the patient, we're wearing PPE, we treat the patient, do the endoscopy. Sorry, we don't do this, but we do the endoscopy. And if they have a dramatic cough, spewing, mucousy moment, we're all protected, but what do we do different? We manage the room differently. I report to the clinic staff that we had an AGP, and the turnover is delayed, the room is allowed to rest before we wipe down, and no one goes back in that room for a defined period of time. I don't know that everyone's doing it the same way, but that's one thing that I think has been quite relatively popular around the States, for what it's worth. I think understanding how we manage the room is different. Things beyond diagnostic endoscopy, or what I call scope plus, flexible fiber optic endoscopy with a vocal cord augmentation, steroid injection for stenosis with fiber optic guidance, anything we're doing scope plus needle, those patients are treated as a high potential AGP, and in our world, they're getting pre-procedural testing. Now, arguably, if we're wearing PPE and we have access to it, why do they need testing? Well, I'd like to know. And, even though we're blessed that our false negative rate for our test in our institution is about 4%, that's good. We do like to know in terms of how we manage the room and how we talk to our staff about it. Many of you probably have this experience. You can go in your OR room with all the information you want, but when that staff hears that there's an airway procedure, they are on alert, and managing and working with them and having them be the medical leader for them is going to be important. Tracheotomy is very interesting. I'll be frank, when we heard the early numbers of the high rate of mortality, these terrible situations, these unfortunate patients and doctors who were losing patients early on, I think in China and in Europe, we were saying, geez, 90% of these people die. I'm not touching that patient. I confess, I was scared. I didn't want to do it. When somebody told me, they're probably not going to make it, I'm like, don't ask me to do a trach. I was afraid. And I think what happened is, particularly in New York, particularly at NYU and a few other institutions, I'm sorry I don't know all of them, they realized that there was either from a resource issue or the fact that they were, because of lessons learned from the early places, the survival rate was much higher. They were having patients intubated for weeks and weeks with big tubes, and they knew they were going to have problems with these chronic intubations. So NYU started doing tracheotomy early, even in the height of the pandemic in New York City. Early, and they were doing a very interesting procedure where they would put a flexible bronchoscope, as I understand, around the endotracheal tube to perform a percutaneous type trach in that regard and reduce the exposure. I did a handful of COVID trachs early on in April, and we realize that these patients do have a better survival rate, of course, than early on, and that hopefully will continue to improve. But tracheotomy needs to be considered in these patients. I think prolonged intubation is bad, and I think while the threshold may not be the same as for a non-COVID patient with the same amount of intubation, I think we need to ask ourselves, why is it that I'm holding off? Is it because I'm afraid for me, which is okay to just acknowledge it? Am I worried for the team? What is it that's best for the patient, and just have that conversation. And one thing that's been particular to laryngology is, early on in the process, we weren't doing jet. We had airway patients, and we liked doing jet ventilation, and we just didn't think that was a good idea. And then Thrive, which is a transnasal high flow, 70 liters a minute, for supporting airway, we definitely weren't doing that. What are we doing now? Well, turns out we like jet. We started doing it again because the relative volumes aren't that great. And even though it's an open airway, all our operative cases are tested preoperatively, but we aren't doing Thrive. Science, no science, I can't answer that, but that's what we're doing. The future is probably going to be fine in my sense for this. I was worried about there was some interest in our field. People don't want to be in a field where they're getting coughed on and splurted at. I get it. I don't think very many doctor practices are going to be free of this, although otolaryngology is front and center. No two ways about it. I thought laryngology might be impacted, but the interest appears to continue. I don't think at least, again, I only know the US system, but the interest in our field this year for the applicants out of medical school is as high as it's ever been, for what it's worth. Who will we see as patients? Well, where did all the singers go? These folks were not seen for routine healthcare. The zeal for these patients to come in and be evaluated, they're walking into the medical center. There's this, they're probably safer at the medical center than you are at the grocery store in some cases, but there is something about this. Performing arts, whether or not their own economics have been affected, where are they performing, right? They can do online, but there are not as many shows. There's no big stadiums. There's no events right now. None of that is coming back anytime soon. I think this iconic or emblematic part of our practice has been affected both from the interest, their ability to seek care, and their work is affected, and we need to be aware of this. There's substantial economic pressure. I think it'll be important, depending on your payer model, if it's pay-as-you-go state or if it's a employer-based insurance model like in the States. How do we maintain value? I mean, there's going to be economic impact from all this. There is, and that's going to continue. I think this is a call to action for our otolaryngology colleagues to really recognize the value of what we do and write it down, study it, report it. As we compete for these dollars, standing up and saying, getting your voice right matters, and this is why, and this is how it matters. Getting your swallowing right matters, and this is why we do what we do. I think speaking about these sorts of things in airway will be important to hang on to the value of what we do. We, at least in American laryngology, have been 2 decades behind hearing research. And I'm just hoping in the next 10 years, we're less than 10 years behind. I don't know that we'll catch up, but I think getting this part right, could this pandemic be part of it? One little silver lining, at least in the voice therapy world, as part of the collaborative model here in the States, is that the patients would come from 3 hours away or fly in to see me, for example, and talk to them about, their globus sensation, which I love, by the way, talking about that. But they wouldn't come see the therapist. And now we're doing almost all the therapy remote. It's getting paid for the most part, and is done in a patient that respects patient privacy, even online. So that's been one silver lining in all this. But getting this right will be important. Who do we see? What economic pressures do we need to address for our patients and our practices? And I think really the only answer will be to arm ourselves with data. I don't know where we're going with this. This conversation is frozen in time. Things will change. But I think having a healthy discussion about who we see, how we see them, what do we wear will be important. Personally, I wear an N95 all day and a face shield from the beginning of clinic to the end of clinic on our patients. They are not tested for routine visits unless they're having a procedure plus. I don't wear an N95 in the OR unless it's a COVID unknown or a COVID untested or a COVID known patient. For routine OR, they're all tested and we just wear a normal surgical mask. I think there's some practice variability with this, depending on, as we mentioned, testing variability, disease burden, and PPE. I appreciate the chance to talk to you. I think I've reflected on what I've seen and sitting behind a keyboard battling for the last 6 months and taking care of some patients. I realize it's different for everybody. I think despite this dark and uncertain time, that there are opportunities to stop, listen, and learn about what we're doing and refine it. I worry about our early career folks who are trying to get going. How are they going to get their patient base? How are they going to write their papers? How are they going to present? Zoom and the other models have allowed us to talk more easily, but I don't know quite how that's going to add into their next 10 years. As a mentor, I do worry about this, but I realize I've been very lucky. Thank you for this opportunity to talk to you all, and I look forward to seeing you again someday in person. Thank you.